Thank you all so much for coming here today. I am Lauren Westafer. This is Bill Soares, and we are from University of Massachusetts Medical School at Bay State. And what we're going to do is we are going to talk with y'all for a little bit about critical appraisal skills, study design, stats, research curriculum, why it's really important, and how to actually get people engaged. It is, in fact, possible in this topic. We do have no relevant financial disclosures. We take money from the National Institutes of Health, so thank you all for your tax-paying contributions. If you're from the United States, we appreciate it. None of those are, in fact, relevant to this talk. Now, why is this important? You're here, so hopefully you believe that this is important, but not everyone does, and I used to not think that this was super important, and it's a problem in research, and part of it is because shockingly, people find statistics and critical appraisal boring. This was kind of news to me. People also lack the motivation to read the primary literature. Sort of like I lack slides. They lack the motivation to read, and then more importantly, they lack the skills to actually go out and interpret the medical literature, which is not only sad, but it's also really dangerous. And so looking at this, I sort of didn't believe it. And then I read more and more literature, OBGYN, internal medicine literature, saying physicians can't interpret statistics and don't know how to appraise the findings in studies or even in abstracts. And I thought, we're emergency doctors. We obviously are better. And so Bill and I did a study, and we found out that, in fact, we're not. Only 3/4 of people could interpret a p-value, just over half an odds ratio, and just over half a confidence interval. How many people do you think could interpret a Kaplan-Meier analysis? Any guesses? 2%. So essentially nobody. And we kind of asked ourselves, why? Why is this the issue? And we found out that's because people have this attitude out there that statistics is boring, and they're not motivated, like I said. They also lack the skills. And so we examined how we were doing this at our institution at Bay State. And what we were doing at that time at Bay State is we had research lectures. We had it as part of the curriculum. We had it once or twice a year for an hour. It was like all the stats you can cram into an hour by sort of like the head researcher, which is really hard to sit through. And then we had a pretty standard journal club. It was after hours, off campus. We were distributed 3 or so articles. Residents of various levels would be in charge of presenting them. There would be food, there would be beverages. People had a lot of fun, but it wasn't because of the statistics. They weren't necessarily engaged, and we weren't sure that they actually learned anything. It was kind of a distractible environment, and people really didn't feel comfortable speaking up because they weren't really taught how to appraise the articles to begin with. So we decided we were going to revamp this.
So we identified a problem, right? Especially with our residents, we were having trouble conveying statistical knowledge and research and appreciation for them to go out into the real world. And so we then attempted to revamp our curriculum. And I think the best way that we can first illustrate this to you is by giving an example. So this is from a lecture that we did. It's on probability and odds. So you're all researchers. You know that odds are incredibly important in what we do, right? Odds ratios, they're also kind of difficult to interpret. They're not intuitive. And we found from our study that residents weren't getting it. So what we did is we created kind of a short activity that we gave in our short lecture to be able to reinforce these concepts. Now, at Bay State, we had Skittles. But we're not at Bay State, we're in Vegas. So at Vegas, we have poker chips. So I want to take a minute and I want to do kind of a quick activity. I need a volunteer. Dr. Wei, thank you so much for volunteering. It's like you just knew. I have in this bag 12 poker chips. 3 of these poker chips are red. What I would like you to do is, without looking, take a poker chip. Now it's Vegas. They will know if you look. Security's right outside. Take 1 poker chip and don't look at it. Keep it in your palm. Don't look at it. All right, for everyone here, what's the probability that he pulled a red poker chip? And then what's the odds that he pulled a red poker chip? Recalling that probability is pretty intuitive to us, right? It's the number of red poker chips over the total. So that's 3 and 12 or 25%. But odds is a little bit tricky. It's a number of red over the number of non-red. So in that case, it's 3 over 9, or 0.3. Now, why does this matter to you? Well, because we're in Vegas. Right? So understand Vegas is a little tricky because they're betting against you. It's odds against. Odds that you won't pull that red poker chip. So you flip it. It's inverted. So it's 9 to 3 or 3 to 1 odds against. Why do you care about that? Well, it's a nice number. Well, it's because we're in Vegas. And what do you really care about? How much am I going to win? So in Vegas, 3 to 1 odds, you multiply by 100. And that gives you a plus 300 line, meaning if I put down $100 that you pulled a red chip, then I would make $300 in profit. That's how they use odds. Now what if I say, well, what I really want to bet on is the fact that you get your 100 back and then you get 300 in profit. Because it comes down to this. What if I said, I want to bet on if you don't pull a red chip. I want to bet if you pull a blue or a white. Then that's 1 to 3, or if you multiply by 100, a plus 30. Which means if I bet 100, I don't get 30 back, I get my 100 back, but I only make $30 in profit. The odds are greater that I'll pull a blue or a white, but I make less money for it. Right? So the big question is, what did you pull? A white. Oh,
Bill, you get to keep your money.
thank God. We didn't know what would happen if someone pulled a red. We'd have to offer something, but we couldn't offer $300. So thankfully, we bet on the right odds. So why do this? I actually literally carried these poker chips from Massachusetts because I knew I wasn't going to win 12 poker chips here. It would be much easier just to put a slide up. But that gets to the theory behind of what we tried to do. Right? You all are adult learners, meaning you learn differently. Right? You have shorter attention spans than you did when you were, say, in 2nd grade. You care about things that are going to change your practice. And if they don't, you don't care about it as much, and that's okay. You want to be active. You want to be interactive with folks. You want to participate. And so we were trying to say, look, we really need to do a better job teaching statistics. We tried to incorporate that by keeping things short, relevant, engaging, flipping the classroom, and incorporating experiential learning. So we're just going to take a couple minutes and go through these. First, keeping it short. Now, as we talked about, in general, for lectures and other things, our attention span is about 10 minutes, maybe 15 minutes. Which is why, I know there's a couple of you looking at your phones right now, I can see, but that's okay. I'm not offended. We didn't spend hours on this lecture. It's totally fine, because I know it's just your short attention span. And that is normal for you. It is normal for you as an adult learner to say, my attention span's off, I'm going to look down, I'm going to do something else for a while. But how does that play into how we teach statistics? Well, we know that statistics in general, it's not the most exciting thing. So I'm not going to captivate people and be able to do an hour. And so instead we said, we really want to try to make it short. Especially when we're doing these statistical topics, which are kind of complex, we want to give it in short bursts, in 15 minutes, so we can keep your attention and not overload you. Now that's different than just sitting up for the hour and going over all sorts of different things. But what it does do is it's a lot easier to prepare those presentations, and it allows for some spaced repetition. Because I can do a couple of short 15 minutes a couple of times a month. And I can space that out and keep people's attention much better than that one big hour lecture.
So tip number 1 was to keep it short. Tip number 2 is to make it relevant. And part of making it relevant, are y'all familiar with the phrase, kill your darlings? It basically means sometimes to make a point or to be effective, whether it's in literature, etc., you have to sever the things that you really care about. For me, this means ditching the nitty-gritty stats. So instead of teaching somebody basically the ins and outs, all the pearls and pitfalls of various statistics, how to calculate them, and exactly what they mean, I had to focus on what my clinician actually cares about, and what I really want to equip them with is, how do they interpret these? If they see them in an abstract or hear them on a podcast, how do they do that? So focus on the interpretation. The other thing is to choose relevant topics.
Oh, Lauren, but I'm the head researcher at my department, And in college, I did this research, true story, evolutionary biology. I looked at sperm size differences in little worms, and I'm the head researcher. That should be interesting to people, right? I should present my research.
I'm sure some of you may be interested in sperm sizes of nematodes. I'm not. So when I choose these lecture topics for my residents, like, what are they interested in, right? What does every EM resident always talk about 24/7? It's things like airway. It's things like resuscitation, anything that involves the word ketamine, anything that's myth-busting or dogma-inducing. Those are the things that capture their attention. And our thought is that if we can get their attention, we can maybe actually subtly teach them things about a topic they don't really care about. So where do we go when we're looking for these articles? I go to places where there's practice pattern variation, where there are clinicians doing different things, whether it's at my institution and I'm kind of have a pet peeve about it, or whether it's at other institutions. I try to pick articles that maybe they're hearing about on podcasts, and maybe I disagree with those interpretations, or maybe I don't, but I want them to actually understand why people are recommending the things that they're doing. And lastly, some of the foundation articles. Why do we do what we do? Why do we give aspirin for acute coronary syndrome in STEMI patients? So we keep it short, we keep it relevant, and the bottom line to kind of all of this is we try to engage them. And we engage certain things when we try to engage our learners, whether it's residents or even faculty members. We do a couple things. We engage excellent speakers. Obviously, Bill and I think that we are those speakers, but we try to, keep people up there that will be a little bit entertaining, but also have the ability to talk about these topics. We try to use fresh visuals and keep things relatively simple to engage them. And lastly, we kind of force them into guided interpretation so that in real time we're engaging them and forcing them to do some of the interpretation that we're hopefully teaching them. And so this is a brief example, not of an entire presentation, just of it as an example of a talk about statistical power. And so instead of going through about how the calculations are done, we do an exercise and we use builds to get them to point out what goes into a power calculation by using something from an article that they were talking about. This happened to be amiodarone in cardiac arrest. So we get them to point out various things and talk about what goes into that and interpret that actual power calculation. We focus, again, maybe it's a little bit oversimplistic, but these aren't going to be, most of these are not going to be statisticians. And so we're okay with that. And then we get them to figure out what happens when you get a result. What happens, maybe say in an underpowered trial, and get them to compare the findings to an actual power analysis and figure out how do we interpret this in real time. So we keep it short, we try to keep it relevant, and we engage them actively and sort of guide them through the interpretation of these things.
And the next thing that we try to do is, in some cases, we try to flip the classroom. So probably many of you are familiar with flipping the classroom, but for those that are not, the idea is that you want to engage your residents or your learners in substantial work prior to the teaching session, with the idea of then that teaching session is less of a lecture at them and more of a discussion, right? This really came up for us with Journal Club. We before probably had a very similar journal club that many of you had, where we said, hey residents, read these 3 articles, and then come to journal club. And what we found was that really the discussion was forced, maybe 1 or 2 people, but we weren't getting a lot of buy-in, right? Residents, even the ones that read the articles, maybe they skimmed it, maybe they were on an overnight, so it was really hard to get substantial discussion. So what we did is we made a few changes. The first thing is that we added a standard appraisal questionnaire. The idea of this is we did it by, this is a randomized trial, this is an observational trial, and we tried to guide them through the article to try to search and just pick out the important points. It wasn't exhaustive, 10, 12 questions, but it tried to guide them through. The other part that we did, which is really the key, is they wouldn't get credit for Journal Club unless they did that questionnaire before. They had homework, right? Oh God, the residents, they're not going to do homework. Really, it was an important part. Because what it does, and the whole idea of the flipped classroom, is you're putting some responsibility on that learner, right? They are there to learn, but part of it is their responsibility to own some of that to learn. And really what it does, we tried to keep the standard appraisal where it wasn't too burdensome for them, but it did. It increased engagement. People were able to discuss. If they forgot, they were able to look back at their own answers. And we had kind of a deeper understanding in Journal Club than we did before. The last thing that we want to mention is this idea of experiential learning. So take a moment. Think back to your residency. Think back to one or two teaching moments that you remember, the things that changed your practice, right? Like that moment of teaching and learning. I guarantee I would be very surprised for anyone, was that a lecture? Right? Like a standard lecture? No one, right? It was a patient. It was a sick patient. It was a good outcome. It was a bad outcome. That's how we learn clinical medicine, right? That's the foundation of clinical medicine. But we're talking about research. And in all honesty, there are very few coding patients that need emergent statistical calculations. Like, you just can't fit it in experiential research in that way. So what we've tried to do is try to do it in a different way. And there was a little taste of that. That's why the poker chips are important, right? Trying to get them to activate other senses. We've flown airplanes for regression. We've done paper toss for interrupted time series. We had them take a random Star Wars knowledge test to do a clinical decision aid to see who was the geekiest person, right? These are easy to do. They don't cost much. But the big thing is, it's not just a dry lecture. You're activating other things. You're keeping them interested. You're getting them moving a little bit. And to incorporate that aspect into research really helps, we think, to really solidify some of those ideas so that you remember what an odds ratio is or how that works.
So in case we haven't mentioned it, we believe that keeping it short, relevant, engaging, flipped, and experiential is really important. But like, how do you actually do this? And basically, we got a lot of buy-in from our educational leadership, but they gave us a lot of conference time and a lot of flexibility. We were able to take that journal club time and shift some conference topics like wellness and other things to that time. So we got conference time dedicated for this. So I guess work in a place that supports research and teaching. But how does this look in practice? So we have a 2-year curriculum for this. And the first 18 months is relatively simple. We do these 15-minute stats lectures, and we have journal club during this time. In the 15-minute stats lectures, these are some of the topics that we cover. We have standard topics that we cover. It's one at a time. It's digestible. It's short. It's quick. And they're things that we believe, and prior literature has said, people should be able to interpret. And then the journal club, as Bill mentioned previously, we do it in small groups. There are 10, 12 people in each group. There's 1 to 2 articles clinically relevant that our residents either really need to know or find interesting or misusing, perhaps. And then they have the pre-work. They have the critical appraisal questions, and they have that homework ahead of time, so they're held accountable. And so that runs for 18 months. And then during the last 6 months, what we do is basically kind of sneaky, is we kind of incorporate the two and do some spaced repetition, just so we keep giving them stats, but they don't necessarily know that we're giving them stats. So we call it a stats review, but really what it is, it's a 15 to 20-minute talk, which is essentially just one new or cutting-edge article that's just come out that people are talking about, that's all the rage, or is a pet peeve of one of us. And we kind of reinforce those statistical topics, and we put it back on them. We have them actively interpret the article in real time while guiding them through it, but reinforcing those pearls, whether it's a likelihood ratio or confidence intervals or some type of analysis. And then during that time, we still have journal club running as well. So ultimately, this is what our 2-year curriculum looks like, and what we found is that our residents actually like it. They fill out anonymous surveys, so it's not like they're just trying to appease Bill and I, but they actually ask for more of it, and we've been incorporating even more and more of this, and sort of when we get busy and are unable to, people sort of ask us to do a little bit more of this, and so we found that they like it, and this is what we're doing at Bay State, and it's because we've got that buy-in, but also because we think that this is a really important priority, not just for researchers, but also for the impact of how they're going to practice clinical medicine in the future. Do y'all have any questions for us?
Yeah, question.
Just going back to your motion, I don't know if this is covered in that session anyway. If you're trying to do this with faculty who work in the community part that's trying to raise their bar, that's a different animal because they're not students per se anymore. They're there on their time looking for something probably quick and short, that's full time. They're not there for training and evaluation. What's your thoughts on that?
I mean, I think that's where our, what we've been doing with it's sort of like a stats review is what we call it, but it's essentially a mini journal club. It's 15 minutes, cutting edge article, but we sneak things in there. We sneak little pearls in there, and a lot of times it's because we catch something in an article that's snuck by peer review that is maybe wrong or misinterpreted, et cetera, and that excites people, but also we intentionally choose things that are like practice changing or people think are practice changing, and so maybe by getting buy-in from them by choosing things that will ultimately clinically impact them, because that's probably what they're there for, and sneaking in the stats.
I agree. I mean, I think that it really requires, which is the hardest part. There's so much good literature, and as researchers, you're like, oh, but this paper. It's culling it down and realizing that some of those, you're just going to present them with what they need, right? You're going to present, if you are in charge of doing education, you're going to present the bullet points. But I think all with social media, we see, even in the community, even everywhere else, like these things come up. Oh, I read this in, EM News. I read this article. I heard it on Foamcast. I heard it somewhere else. And I really want to know, but I'm not sure. And I think once you have, as adult learners, if you have a group that has that engagement, then that's the article that you can use and go into a bit more depth. And, again, we have a special with residents and medical students where we can do some more of that flipped classroom, and that may not work. But the other components of keeping it relevant and engaging to people, and hitting those bullet points of this is how I, as a person who has a little more knowledge and research, reads this article. Because often I think what we find is it's not one of those extremes. They get the extremes, right? This is bad. This is good. Why are you not doing this? It's malpractice. Why are you doing this? It's malpractice. And we all know a lot of research it's more subtle than that. And so I think a lot of people are really looking for, no, what does this really mean? And how much of effect is that? So I think picking out those articles that are that relevant and people are already talking about really helps. Other questions, folks? Yeah, in the back.
I think this is great. What about sharing this on a website so people can actually take your lessons and actually use them?
Oh, like our individual lectures?
Individual lessons, slides. What about sharing this with others who can use it for their residents, but they're not sure exactly how to translate what you said today to actual lessons?
Absolutely. So currently I have a draft of a podcast. The name is Stat. If you want to steal it, feel free. I have some draft episodes. The problem is bandwidth. Right now we both are 25% clinical, we're 75% research. The time that we have for individual projects is low. So if you would like to volunteer to help, I think that's probably ultimately the way forward, and we've talked about that. We just haven't had the ability to put it together yet, but ultimately you're right. Exactly what we need to do is to put it out there. Also on our list is to more rigorously evaluate actual outcomes for this and test them like we did initially, which is also how we got buy-in, as we shamed them by showing the stats of how they performed publicly and nationally. But you're right, those are both on our to-do list, but if anyone wants to help.
Yeah. And I think there are some things that translate over well, like giving the general topics and the activities, giving the standardized questionnaires that we use. But some of the other things, part of it is that you have a person or someone who develops it into their own. Because that's the strongest, because we can get up here, but we know our residency and what's accepted and what's not, right? Can I call this person by their first name? How formal, informal? And so it's more about sharing kind of the concepts and the framework and then being able to plug in your own to that. And it is definitely, as well, something that we will try to do. We are in, I think, the third or fourth year? I think we've completed now 2 cycles. So we've now have it to, I think, a point where we have our lectures and we understand for ourselves. So, yeah. Questions? Nice.
Well, I mean, it is if you subscribe to the EMJ Club podcast, which is there's some crossover there, but.
That's the other. We didn't put that. That was going to be number 6, to have a slave labor pool, but we figured that we didn't have time. It was a 20-minute lecture. Thank you, everybody. I don't know if folks are coming in, but we're happy to answer questions up here as well.